Sorry.
All right, so we have another question up on Slido. So I want you to think about this. So in adults, do you think that voice disorders are more common in males or females? So right now, I'm going to show the results here. Can you all see the results on your own screen? So there are about 29 of you have responded so far, and majority, so 76% of you say males, but in fact it's females. So you will see a lot more females coming in with voice disorders. All right, so the next question then, we're gonna go to, how about in children? What do you think? So same, I don't know where our screen went. Males or females and children? And you'll see both. A lot more common to work with adults with voice disorders than children. It's kind of a low incidence in children, but it definitely still happens. And about 82% of you said males for children, and that is correct. So in children, more often males will have voice disorder, and in adults, females. Does anybody have any guesses as to why? Or any thoughts on why? I don't actually know why, so I'm throwing that out there to you all. No? Okay. All right, so we're coming back to our PowerPoint. Bear with me as I just keep switching screens all over the place. All right, so can you see my PowerPoint now on your screen? Okay, cool. All right, so normal voice, it's always good to know what a normal voice is like before you start talking about disordered voice, but you need a lot of power and airflow from the respiratory system, okay? So someone that has something wrong with their lungs or their respiratory system is gonna have a really hard time like producing enough power and oomph to get all that air out through the trachea, through the vocal cords to produce a good, strong, normal voice. You also need a lot of laryngeal muscle strength. You need balance and coordination. Sometimes in the hospital, when somebody's coming off of like a breathing machine, they might have a really hard time coordinating all of that muscle movement, right? Because they haven't used their voice, they haven't been swallowing, they haven't been using any of those laryngeal muscles. So they're not quite strong and they're not quite coordinated. So they might have some trouble with voice. And same with like your pharynx, the oral cavity, the nasal cavity, all of those things have to really work together to produce a normal voice. And someone, Sierra mentioned in the chat too, in her family, male cousins had sisters who talked for them. That absolutely happens a lot. That's pretty common. So thank you for sharing that. All right, so I have a video here. I don't know if you guys have seen vocal cords before or what normal vocal cords look like. So we're going to watch this video. Maybe. Oh, Jake, why won't this work? Ah, there we go. All right, and you should be able, I think I shared the audio from my computer. So we'll see. Let me know if you can't hear it. So poor lady, not very good at singing. I think she did good. She did better than I could. So that was a video stroboscopy, and we'll talk about that a little bit more later. But the image, and actually the video is kind of, I don't know if that's the lag or if there was actually a lag, but it does kind of slow down her vocal cords just to match up with the sound. So sometimes when you're watching a video strobe, it might kind of look like things are it's kind of in a slow motion almost. So what are some things that you noticed? And we can go back to, going back to here, obviously we have her true vocal folds here, right? What do we notice about like their color, their shape? What are some things that you noticed either when they're sitting still or once she starts singing? What are they doing? White, and they're opening and closing, absolutely. What else? Did they change throughout? Did you notice that is it just like an open and close? What are they kind of doing when they're opening and closing? Or what does their shape look like? Absolutely. Lengthening and shortening. A lot of openness for the air to flow. And they absolutely stretching out when she reaches a higher pitch. So just like Andrea said too, the lengthening. So you notice kind of as she goes through, those chords are either going to be like really long and skinny when she's getting into those high pitches, or they kind of are short and fat and they're coming together. Either way, they are opening and closing, and they kind of make that wave motion. Okay, so they're not just opening and closing like a door. There's some flow to it. And that's one of the things that you'll assess if you're ever looking at a video stroboscopy. And absolutely vibrating. So you have like good vibration in those chords. That's helping get that sound out. So when you're doing a voice assessment and when you have this imaging to look at, you're really going to be looking at those true vocal folds, those pearly white ones, and also the false vocal folds. So we'll see those a little bit more in some other videos later. So those are going to be really important areas that you want to check out. Her arytenoids, so these are going to be like helping pull those chords together. So you want to look at the whole big picture, but those chords in particular are going to be very important to keep an eye on. All right, so there's a few different categories of voice disorders, and I have a lot of more videos that I want to get to. So we're going to kind of go through this part a little quick, but if you have questions, please chime in or write it in the chat. So you might have an organic voice disorder. So that's something that's going to result from a change to respiratory, laryngeal, or vocal tract mechanism. All right, so there's going to be a physical change to the voice mechanism. There might be nodules or like little like bumps on the vocal folds. A granuloma could be like a really big bump that's blocking the cords from closing together, or it could be blocking the airway. So it's blocking some of that airflow. There might be other structural changes to the larynx. As we get older, there's a lot of changes. So there's something called presbyphonia, and that would be just changes to your voice as you age. So, you know, some older people might notice that their voice is a little bit more gravelly or a little bit weak. That's because they have a lot of changes in that area. You might have neurogenic changes too. So any problem with the central or peripheral nervous system can make changes to the larynx as well. That's going to cause voice disorders. Someone might suffer from vocal fold paralysis. So instead of both of those cords coming together nice and pretty, one of them's not moving at all. So now you have this big gap in between, and you're going to hear a really breathy voice from that person because their chords just aren't coming together to make voice. Some other categories of voice disorders you can have are functional voice disorders. So this might be somebody like a teacher or maybe a football coach or someone that's not really using their voice in an efficient way. So maybe they're not drinking any water, they're screaming and yelling a lot, they have a lot of tension in all of their muscles here, and they're overusing their voice. So somebody like that might come in with vocal fatigue. They might get muscle tension dysphonia. So all of those muscles there in the throat are going to get really tight, and that makes it hard for that nice, easy flow of the vocal folds. So they're going to notice some trouble with their voice as well. Psychogenic voice disorders are also fairly common. So someone that has chronic stress disorders or anxiety, depression, things like that can also contribute to voice disorders. And then it's really important to know that a lot of these voice disorders aren't necessarily one. They might have a little component of multiple categories affecting their voice. A lot of people come in with voice disorders and they've been to a lot of people. So they've seen an ENT, an ear, nose, and throat doctor, they've seen an allergist, they've seen a pulmonologist, they've seen a speech therapist, they've seen a physical therapist, and no one can really give them a good answer. So then they have this other element of anxiety and depression and the feeling that no one can help them. And people kind of tend to say that sometimes, like, people coming in with voice disorders, it's like, oh, they're just crazy, or there's nothing actually wrong. But there is, and it's just this common misconception. These people, it's like there's no real clear answer, so they get kind of lumped into, well, we don't know what's wrong. So kind of something to keep in mind. An evaluation of someone with a voice disorder, it's going to look a little bit different depending on what setting you're in, but obviously you're going to want to take a really good case history. So you want to ask a lot of questions about hydration, caffeine intake, smoking history, alcohol intake, how much they use their voice, what kind of job they have, where do they live? Do they live by themselves? Do they live with, do they have 6 kids at home, so they're constantly trying to scream or yell over other people in the house? All kind of good things to paint a picture of how that person is using their voice. You definitely want to see what other medical professionals have said. So have they seen a pulmonologist? Have they seen an ENT? GI doctors a lot of times too are on board, and they've prescribed maybe medication for reflux or things like that. So all good things to keep in mind. The speech pathologist plays a really good role on the medical team, but we need the input from all of those other specialists. There's a lot of self-report questionnaires that speech pathologists will have clients fill out. So this one's called the Voice Handicap Index. And if you click that link, it should take you there. But essentially, it just asks the patients how they are doing. So how, like, do you feel like your voice trouble has socially isolated you? Does it make you feel like you can't be yourself? Do you find yourself avoiding situations because of your voice? So it's going to ask them a lot of questions like that. It splits it into 3 different categories, and then you calculate the score, and you can kind of see how severe their voice disorder is based on their perception. So that didn't open for me, but it'll probably open for you later if you want to take a look at it. It's pretty common though to use. And again, nice to get an idea of how that person feels about their voice. Any questions or anything so far? Y'all doing okay? Okay. I'm stuck on my PowerPoint. Let's see. Well, oh, it's because it's trying to open this and it's hiding. So this is the Voice Handicap Index. It was trying to open it on another page. So these are kind of some of the questions that they would ask just to get an idea again of how that person feels about their voice disorder and how it's affecting their lives. So it ends up giving them a mild, moderate, or severe index there. All right, so I don't know if I missed some here too. I did. Okay, so the other thing you're going to look at is an oral examination. So you want to look at the structure, their symmetry, movement. You're going to watch tongue. So all of that stuff that you would do in a normal full speech evaluation, you're also going to want to do here. The other things it will include are a little bit of a respiratory examination. So we're going to take a break real quick, and you guys are going to test your own maximum phonation time. So to do that, essentially a maximum phonation time, you want to know how long that person can sustain the ah, so just like that ah sound, Okay, to get a better average, you're going to do it 3 times. So you're not just going to take one of them. We want to take 3 so we can get kind of a sense of what their average is. So you can all keep yourselves muted, but what I want you to do is time yourself. So take your timer out on your phone, and you're just going to take a real big deep breath in through your nose, and then start and keep your timer going. See how long you can hold it out without straining. So once your voice kind of starts to cut off, or you feel like you can't go anymore, just stop it right there. Stop your timer, jot it down. Take it 3 times, and then we're going to talk about our averages. So we'll go back to Slido once you're done with your average. And you should be able to answer. So I kind of just put some ranges in. 5 to 10 seconds, 11 to 20, or holy moly, you went over 20 seconds, you're a superstar. All right, about 15 of you, 16 have answered, so we'll give you another minute or so. Sometimes it's nice to model it for the patient too, so you can give them a good example of yours, but then you really want them to try to do it on their own. And I feel like some people just really try to go as long as they can, and it starts to at the end, just cut them off, because that's cheating. All right, I'll give you guys another minute to finish up. Looks like it's close. It's pretty close. So 43% so far said you went over 20 seconds. And then about 57% of you got in the 11 to 20 second range. So both are very good. I'm glad you're all over 5 seconds. So for males, the average would be between 25 and 35, which seems incredibly high. Females more between 15 and 25 seconds. So there are your averages. All right, so the other thing that you can do, so after you do that maximum phonation time, usually we almost always do it with the ah. Sometimes people might take like an E sound, but usually the ah. The other thing that you'll do is an S to Z ratio. So essentially kind of the same thing as far as, I lost my chat box. I'm just gonna find it real quick. So S to Z ratio. So you're going to do the same thing where they're going to kind of take a big deep breath in through their nose. This time they're going to exhale with a S sound. Again, same thing, you'll time it. I would take about 3 of them at least, just so you can get an average. And then you'll do the Z. So you have the voiceless and the voiced consonant, okay? And then you really want that S to Z ratio to be 1 to 1. So as long as somebody, that one doesn't matter as much, so just say it's like an 8 seconds and an 8 seconds. That's kind of the same credit as getting like a 15 seconds and zzz. You just really want the ratio to be 1 to 1. So that's going to give you a little bit of insight to their respiratory power. So some of the other things that you can do are, this one's called the grabus, so you'll hear about this a lot. And this is just based on the clinical judgment of the speech pathologist. So essentially, as the speech pathologist, you would listen. You'd usually take like a sample, right? So you might have them read something like the Grandfather Passage or the Rainbow Passage, so you can actually get a good sample of their voice for a while, and then you would rate them. So on the grade of their voice, the roughness of their voice, breathiness, asthenia is weakness, and if there's any strain. So you give them a number from 0 to 3 for each of those. But speech pathologists really like that. It is kind of subjective, right? It's not, it's just whatever the speech pathologist is hearing, but everybody kind of uses the same scale. The CAPE V is another one too, same kind of scale idea where you're going to rate them as mild, moderate, or severe. Something that somebody taught me at one point was like mild would be like maybe you hear them out in public and you kind of think like, their voice sounds kind of odd, but you don't really think much of it. You just keep talking to your own friends. Moderate is like that's going to kind of make you start to turn your head and you're thinking like, oh wow, that voice is different. That there's something going on. And then severe is like I am like whipping my head over there and being like, wow, who is talking like that and what's going on with their voice? So that kind of helped me. So you'll also look at resonance, phonation, and rate as well. All right. So why? All right. And then imaging. So imaging is going to be really important. So that's what we're going to spend the rest of the time talking about. Video laryngostroboscopy. So that was like the video that we watched before. It can be rigid endoscopy. So that one is like, I think I have a better picture. This video here is a gentleman just talking about video stroboscopy. I'm going to skip that for now just in case we don't have time. But this is what the endoscopy unit might look like, right? So you have like a nice big computer that you're going to see your actual images on. It's going to be recording decibels and all of the sound measures that you need. It's going to have a place for you to hook up your scope with the camera. Okay, so that's what this part is here. They do have some portable laptop ones that people are starting to use. That's one we're trying to get at the clinic right now, in the speech and hearing clinic on campus. But that's kind of nice because there's a lot of people who maybe can't get to a hospital. So you can bring that portable laptop unit to them. And there's disposable scopes now, which is also pretty cool. So these are the different types of scopes. So this one's the rigid scope. And this goes, so you're essentially kind of like holding that person's tongue down and you're putting the scope into their oral cavity. And there you can see like the light source, it's shining down right over. So you get like a really pretty close-up view of those vocal folds and what they're doing. Some people get a little gaggy, as you can imagine. So this one's kind of sometimes tricky to pass on someone, but you get a really good, pretty picture if you can get the scope there. The flexible scope is another option. So this flexible one is going to go through their nasal cavity and it's going to shine down, again, looking at the same area. So you're right over the trachea, right over the vocal folds. The camera on the flexible scopes isn't as good, so it's just not as clear of an image usually, but you do still get some important information from it. Okay, so now we have more pretty pictures. And I lost the view of your faces, so I can't see anyone's faces. I hope you're all doing well. Any questions or anything? No. Okay, so one of the things that you're going to want to look at anatomy-wise, you might see some hyperfunction. So we talked about earlier, so we have the true vocal folds right here, and then over in this area, the ventricular folds or false vocal folds. So a lot of times you'll see, especially with like muscle tension dysphonia and things like that, you'll see that those false vocal folds start to do a lot more work if maybe those true vocal folds aren't doing what they're supposed to. So if the true ones aren't quite coming together, or if there's a lot of tension in that area, you'll see those ventricular folds overcompensate. Okay, so they're almost entirely touching. You can barely even see this person's true vocal folds because of how much extra work the false ones are doing. And then this picture in the middle here shows more of an anterior to posterior squeeze. So it's kind of like coming down, like that top and bottom portion are kind of squeezing together as well. So this person's going to have a pretty strange sounding voice. All right, and I'm going to play this video here of someone with hyperfunction. Oh my goodness. There we go.
Come a little higher.
So you can kind of see those false folds. They're overlapping a little. And right there, they just almost completely touched.
Keep going. A little higher.
She's going to cue him to do some high pitches, some low pitches. You want to see it. You want to see the range. So really high there for that last one.
Down low. Any lower than that?
So you really don't want to see, in comparison to that first video that we watched, that was more normal. This one you can see a lot of that tension and squeeze there.
Control pitch. Do one more. Big breath in.
And the speech therapist might try some strategies while he or she is in there too. So she had him like clear his throat, so you can try to see if, you know, maybe that helps with the clarity of someone's voice. You're also going to want to look at color. So the color of those true vocal folds, right in the beginning, those ones that we looked at, they're nice and like pearly white. So these ones, obviously you have some hemorrhaging on this cord over here. It's also good to keep in mind when you're looking at these pictures, everything is opposite sidewise. So this side over here, you're actually looking at the left fold. So the left fold has hemorrhage. So it's also important to know that speech pathologists can't diagnose anything like that. So you're not going to go in there and say, oh, wow, the cord had a hemorrhage on it. You're just going to describe. So you would describe on this one that you're seeing on that left vocal fold redness, bright red across the whole fold. So you'll also want to kind of talk about location. If you see it's something on the upper third or half or lower third, and then the physician could go in and take another look. Yeah, okay, so the asymmetry is really hard too as far as camera angle. Perfect, thank you. So camera angle is kind of tricky, more so with the flexible scope. So when you're going in with the flexible, because you're on one side or the other of the nose, you end up kind of being a little bit angled off. So you might see a little bit of asymmetry there. This one's like with the rigid scope, so she should be a little bit more center, but I mean, you're right. I think that this, let's watch him again. I mean, I think that I would say that this one is coming over a lot further than the one over here on the right side. And you'll see when you see him come down like that too, so that one's like coming so far over where it's kind of covering the back of those folds. People might call that hooding as well. You might see that in a report. So it's like the arytenoids are like hooding or covering the vocal folds. Then we have, so going back to these hemorrhaging cords, we have the one on the right is resolving a little bit. So now it's looking a little bit yellowish. So again, in your speech report, you're not going to write that they have a resolving hemorrhage, but you will describe the color for the physician. And then if they want to go down and take another look, they absolutely can. So we have another video here, and this one is the hemorrhage cord. Great question, Kaylee. So what would cause a cord to hemorrhage? It could be a lot of things. Usually it's some sort of trauma to the cords. So it could be from an intubation. So if the patient was in the hospital and they had a breathing tube put down their throat, if that tube like hit that cord, that could cause that, or even some sort of like vocal trauma with like major overuse of the voice. I think that would be less common. But yeah, usually it's some sort of trauma that happens to that area. So I would say most typically from a breathing tube. Great question. So you'll see in that one too, what did you notice about that cord? So that hemorrhaged cord, what is it doing or not doing in comparison, again, to the normal one that we looked at in the very beginning? What's kind of different about it? And what are you noticing just overall here? Any thoughts on that? You can't really hear this person's voice very much. So you'll notice even in that other one where we had the hyperfunction, you could hear that gentleman's voice pretty loud. It definitely looks like a hemorrhage. So what was that cord doing though? Was it moving the same way as the one that wasn't hemorrhaged? Doesn't move as much, I would agree, Audrey. So that one's, you see a lot more wave over here on that. So the one on the our left-hand side, see how it's still doing that mucosal wave is what it's called, but that hemorrhage cord really doesn't have that. It's kind of stiff, right? So because it's filled with blood, so it doesn't have the flexibility that it should. And now because it's not very flexible, because it's not like flowing and moving how it should, we have a big gap there. So those cords aren't able to close, right? So she never gets good closure. There's always like a big open space. So that space in between the cords is called the glottis. So you might hear in a report that would be called like a glottal gap. Somebody might say it's like well, they would just call it a glottal gap. So, and they would say for like an anterior to posterior glottal gap. So some people might just have a little bit of a gap in the very, like the posterior part of the cords. In this case, she doesn't really get any closure. And then as we're watching this video, you can't really hear her voice. So she's not able to produce much voice because those cords really aren't giving her much. And it doesn't sound like she has a lot of power, respiratory power either. So some of the other things that you might be looking for. So again, we have a nice good example of what normal would look like. Inflammation on the cords is something you might also notice. So this one here is polypoid chorditis. This is also called Ranke's edema, or you might hear it called smoker's polyps. So people other than smokers can get Ranke's edema, but not as common. It's very commonly seen in someone with a history of smoking. So obviously they're not very smooth. We have kind of bumps on them. You can see they're pretty veiny. That doesn't necessarily have to be tied to the Ranke's edema, but neither of the edges of these cords are very smooth. Okay, so you can imagine when they're trying to voice and come together, it's not going to sound quite as good as a normal voice. These cords over here on the very far right are just, they're just labeled as generalized edema, but they're just swollen in general, so they might not have a reason for it. I'm not sure in this person's case, but you can tell how much, they're much, much bigger, thicker, swollen than what a normal healthy cord would look like. All right. So this person has some pretty significant bumps, right? And the bumps are touching, but nothing else is, right? So she's not getting much closure on her full cord. It's really just those bumps in the middle that are touching. And what does her voice sound like? So what do you notice about that sample? So obviously we know that just right where those bumps are touching, the voice does sound pretty hoarse in that one, I would agree. What else? Is it loud? Pretty strained? Loud, quiet, breathy? Yeah, I'd agree. A little bit raspy or quiet. Yeah, she doesn't get a lot of good volume out either. Very weak. So with this sample, so those are obviously pretty big, prominent bumps. And again, as an SLP, so we might see, you'll hear about like polyps a lot or nodules, things like that. You'll hear about that a lot like in the media, like if like Adele has like nodules or someone canceled their tour because of vocal polyps. So a speech pathologist can't diagnose that. Typically though, if you're seeing a polyp, it would just be unilateral. It would be on one side. With nodules, you'll usually find them more like this, so more bilateral, and they're going to be touching. They're going to be like at the very same spot on the vocal folds. So again, in your speech report, obviously that's a pretty significant finding. Typically before the person gets to the speech pathologist, an ear, nose, and throat doctor has probably scoped them first to look for big abnormalities like this. But I would still mention this in my report, and I would again just talk about the location, what they look like. So 2 bilateral symmetrical bumps in the medial portion of the true vocal folds, touching on phonation. So just describing what you see. But again, she's not able to get full closure of her actual cords because those bumps are kind of blocking her way. So question in the chat about being sick. So if your voice kind of gets raspy due to postnasal drip, what's happening? So in that case, it's honestly usually like mucus and that gunk that's like kind of attached to your cords. So in one of those first videos, it wasn't that bad, but there was like a lot of, that gentleman had a lot of like saliva and gunk kind of like sitting on his cords. So a lot of times it is from that. You might just have extra stuff on your vocal folds that you're not able to clear. Or you're getting that postnasal drip. So this whole area can be kind of irritated and red. If you have like reflux or something like that, your posterior pharyngeal wall, so we can't quite see it on this video, but like kind of like along the top of where the scope is, could be like red, bumpy, irritated. So typically your cords still should be able to close and they should be moving like normal, but maybe they're just a little bit weaker, or they're kind of like battling all the extra gunk that's in that area. So then as you start to get better, as you're able to kind of clear your throat and get that gunk out, your cords can, you know, get back to their normal function. That's typically what's going on there. So closure patterns, we kind of talked about this like from the last video, but again, if you have any kind of bump or lesion, it's going to affect the actual closure of your vocal folds. So normally you should get this kind of closure, right? So they're touching like top to bottom, and that's going to help produce really good, strong voice. In this case, there's a lesion on one side, so those cords aren't going to be able to touch. And here we have bilateral bumps or lesions, not as prominent as something like this one, right? This one's probably a polyp, even though I'm not supposed to say that. But with this, you can see on both sides, they're kind of bumped out in the like middle-ish there, and it kind of creates an hourglass shape. So you might see that terminology in a report too.
There we go.
So this person has that lesion in the middle part of their cord. That was a really quick video. But again, it's just that.
There we go.
So that the middle part is touching right there. You might also see somebody talk about like a lock and key. Not particularly on this one, but sometimes if somebody does have a pretty prominent lesion or bump, the other side of their cord might kind of be like indented almost. And then when they're touching, it's almost like, again, they'll call it like a lock and key, but it's like that bump part is kind of going into the part that's a little bit more indented just because over time it's created that sort of pattern. And that person's going to have a really raspy or weak voice as well. So in this person, same thing. We see that like hourglass closure. So you're not getting that full closure from top to bottom. You have a gap a little bit on the top there and on the bottom. So the closure of those chords is in the middle.
Again. And give me a low.
So she gets okay voice out. We can kind of hear her, but definitely very raspy and breathy for her voice. Oops. So those are all my videos. So if you guys go to the University of Wisconsin website, it is actually pretty cool. They have a lot of, here's all the pictures of everyone again. They have a lot of really cool simulations. So I would recommend, if you're interested in voice at all, and it's so cool, so why would you not be? You can go to all of these different like patients, and they have different questions for you to answer. They have different voice samples that you can listen to. They ask really good questions about, so you can kind of decide like, oh, you know, what did I thought that this was mildly breathy and moderately strained, and you can go ahead and put that in, and then you can compare it to what another speech pathologist would say about that voice. A lot of it just comes with practice. So the more samples that you listen to, the more people you listen to, the more chords that you see, the better you get. So I would definitely recommend checking this website out if you are interested in practicing or learning a little bit more. And then also in this PowerPoint somewhere, one of the videos that I skipped was just a video about video stroboscopy in general. So if you do want to go back and watch that, it's just an ear, nose, and throat doctor kind of explaining what video stroboscopy is, why we use that study, and the kind of things you can see with it. So that was somewhere in the PowerPoint if you want to go back and watch that. But that's kind of all I have for you. So I went to a really cool continuing education conference at Vanderbilt a couple years ago to get trained on video stroboscopy. So a lot of the pictures and videos came from that course. And they are definitely experts there. They work with a lot of big stingers, and yeah, so voice is a very kind of specialized part of speech pathology, but very, very cool. So what questions do you all have? Anything?
Before we do questions, everybody unmute and applause.
Oh, wow. Just little, I want like little finger applause or a little golf clap. Yeah, that was good. I lost sight of all of the faces during it, so you all may have been like the whole time and I had no idea, so it went well for me. Any questions, comment? Does anybody have experience working with someone with a voice disorder, or has anybody here experienced a voice disorder? Have any of you, I'm sure we've all like lost our voice at one point, but has anybody ever had nodules or polyps or anything like that where they had to see an ENT or get scoped by a speech pathologist? Or do you know anyone who has? Ah, Sierra has a lung disorder. That'll absolutely, so like we talked about, that respiratory part of voice is huge. Yeah. And a friend with vocal cord dysfunction. So we hear a lot about vocal cord dysfunction. It's a pretty kind of controversial diagnosis a little bit. It's really hard to, so vocal cord dysfunction is, my cat has decided to join us for the last couple minutes here. But vocal cord dysfunction, your cords may just like slam together, right? So you might just be, it happens a lot in athletes. They see it a lot in athletes, and also in like kind of like type A, like really like stressed out younger females too. They see it a lot. But that person might be like working out, or maybe they just ran a mile and they're just hanging out, and all of a sudden it's like they just feel like they suddenly can't breathe. So their cords are just kind of like slammed together. It might be triggered by a smell sometimes. It can be a pretty sensory thing, but obviously pretty scary to have your airway close up. So a lot of times if you go to speech therapy for something like that, they work on rescue techniques and what you can do in the moment to open your airway back up and return your breathing and voice back to normal. And it looks like Jess worked with someone who had a problem with voice, so struggling with volume control, so due to a hearing problem. So absolutely, it's like with all of this speech stuff, everything is so interconnected. But yeah, if he wasn't able to hear his own volume, I'm sure he had a hard time modulating his own voice. Yeah, that's pretty interesting. Cool. Well, thank you all for listening to me talk about something I like to talk about.
Yeah, thank you. That was really an excellent lecture.
Absolutely. Yeah, cool. Well, I'll hang out if anybody, or I don't know, you want me to, should I wait for anything else?
I mean,
Oh,
I don't
there's
know.
my
They
dog
usually
now.
start heading. Oh, well, I guess I should say again. Yes, word of the day, exactly. It's pineapple. Yes.
Pineapple.
And the
Pineapple.
slides are on Canvas. They're already there, so you can check them out. And I think links to the videos are in what you sent to me.
I
Pretty much
believe so,
everything is
yeah.
already there. Yeah.
Yeah, yep, everything should be in there. Yep. Yep. Yeah.
And then now they'll probably just start filing out.
Filing out the Zoom door.
Yep, there they go.
Quiz will be up after class.
Yes, thank you. Yeah,
I don't
exactly.
know,
Quiz
I'm
after
assuming.
class.
Quiz after class.
Oh, no, there still is going to be extra credit. I just need to get some of my studies up and running online, and then I'll send you the links. And then you can still get extra credit that way. Yeah, no problem.
Off they go. Then there were 10. How fun. All right. I was like started to get a little stressed out because I like kind of forgot I was doing this, and it was one of those like popped up on Outlook, and I was like, oh,
Like, oh
yeah.
no. Yeah.
So yeah, but well, and then I had asked because then I was like, yeah, I'm pretty sure we're still, because actually I had 2 guest lectures in my last couple classes. So I was like, and one of them was like, oh, it's on Zoom. I don't know. And I was like, you can't back out. Like, don't back out on me. So I was like, I don't want him to think I'm backing out because of the Zoom situation. So anyway, but
I mean, this
kind of one of
works.
those, it was like somewhere on my radar, and I kind of, it was like, oh yeah.
Yeah,
So
they all came up so much faster because of, I mean, spring break,
yeah.
they're so far
Oh my
away, and
gosh,
then everything
yeah.
happened.
Yeah, all of a
It was,
sudden. So yeah, cool. Well, I'm glad thanks for having me again.
of course, yeah. It's always a great lecture when you're here, so it's great to have you.
Well, you're too kind. You're too kind. All right. Well, have a good rest of the day, and I'm sure I will see you on Slack or Zoom or somewhere soon.
Yeah, I'll be around, yeah. See you
Yeah.
later.
Okay, sounds good. All right, bye.
Bye.